of the core. This is very important. Pelvic floor is a very important muscle from this group, core muscles. So core is made up with the diaphragm. There's a upper side, superiorly there's diaphragm. The anterior, we are having these abdominal muscles. Posterior, you have all these back muscles. And the lower side, the downward side is the pelvic floor. So this whole, if this is a box, for example, if I have, okay, assume like this, okay. So in this diaphragm, pelvic floor, and anterior and superior, this is the muscles. So this whole box, the cylindrical shape, is surrounded by the very important muscles. So yeah, we know that we got pregnant. We are getting pregnant during pregnancy. There is an expansion going on. A lot of changes are going on. Now, how this muscle is kind of, one bechari muscle, I will say. Okay. So what makes it bechari muscle? Why it is weak muscle? So I will ask you this question at the end of today's session, if possible, or when we'll meet you in that workshop. Why God has given us this muscle, and this muscle is prone, like always at a risk. Gravity is keep pulling it downwards. Internal pressure is always keep falling from the up. So why this is going on with this pelvic floor only? So let's try to understand the pelvic floor. And when we are talking about the pelvic floor, so this whole cavity, you have to understand that not only like so far transverse abdominal, all the muscles you are aware about, diaphragm, you are aware about that. The posterior, all back muscles, we are dealing with the patient. But pelvic floor, when we're talking about this, so now let's try to understand this very, very important floor. What is going is holding everything. So downwards, this floor is holding you. So it is the main responsibility of this is holding the things on the right place and supporting everything. Ligaments are also there, connective tissues are also there, structures are also there. So many things are there, and fascias are also there. So let's try to understand this pelvic floor, the concept of pelvic floor. Today's workshop, today's webinar is very important because at least you will have some understanding about the anatomy and the physiology of the muscle. So the day when we will see each other, we can save some time, and that 2 to 3 hours we can spend more into practical sessions, because practical is very, very important. I will, throughout these 7 days, I will keep sharing every day some new information with all of you. So please spare some time. So like, I really want you to go through the conditions which affects the pelvic floor, visceral conditions. So if there are organs, like for example, if you just see the pelvic cavity, so starting from the anterior, and when we are moving towards the posterior side, right now, if you want to palpate your pubic symphysis anteriorly, and then you will palpate your tailbone posteriorly, and both sides you are having this pubic bone, so ASIS is there. So you can palpate these things. So anterior to posterior, when you will travel, so we are having the bone, the bony whole structure, the walls, and we have pelvic organs. The first organ, which is just behind this pubic symphysis, is bladder, which is very important. And urine incontinence, what the problem we are like very, very commonly the problem is there, and we heard this as well. So that is a problem of the related to that particular organ. So bladder is there. And then behind the bladder, what is behind the bladder? What is behind the bladder, everyone? Anyone of you?
Rectum.
Sorry?
There is the bladder. Behind the bladder is the uterus. First, there is a pouch of Douglas, and then there is the uterus.
Okay. Something else? What is behind the bladder?
Rectal canal.
Vaginal opening.
Vagina.
It is a vagina.
Vagina. Yes, Dr. Richa, it is vagina. So behind the bladder, we have the vagina, and behind the vagina, we are having rectum.
Right.
So now, where is uterus? Uterus is on the top of the bladder. So if this is a bladder, and this is the, now every 3 organs, this is the bladder, and this is the uterus, which is on the top of this, and then we have a rectum. So these 3 organs are very important, from anterior to posterior. And all these three organs has some canal, has respective canals. For this bladder, we are having urethra. Then this uterus, we are having vagina, and we are having a rectum, so anal canal. So three things are present there: bladder, uterus, and rectum. And the canals are, bladder is having urethra, uterus is having vagina, and the rectum is having anal canal. Out of this, the uterus is present on the top of the bladder. So this can give you idea that during the pregnancy, when the uterus is getting bigger, all the force of the uterus is going to fall over the bladder. That's why during pregnancy, the urinary frequency is always high. Okay, so this is one reason why females are more prone to have like when the frequencies increase during pregnancy. And the second thing is, during the pregnancy, there's a relaxing hormone which is going to increase the renal system, the glomerular filtration rate. So that will be 50% increase. So the kidneys and the ureters, everything functions as increased. That's why more functioning, more filtration of urine is going on. And that's why the bladder is receiving more amount of urine during the pregnancy, throughout the pregnancy. Okay. So now when we're talking about this first organ, bladder, so something can affect bladder. Anything can affect bladder. What? For example, some infection, UTIs are very common. And any infections can go through, by passing through this urethra, that infection can go towards the bladder also, which can give a condition to the patient, to the person, inflammation of the bladder, or in other form, we can say interstitial cystitis. If this interstitium, the lower inner layer of the bladder, will get inflamed, and because of any irritation, any infection. So that swelling which is going on inside this bladder can reduce the surface area. And this is also going to increase the frequency of the urination. And so this is something which affect the bladder, can affect the functioning of the urination frequency. Okay. Second is, if something happened with the canal, urethra, what can happen with, for example, if some obstruction inside this, an infection inside this urethra, some swelling, so narrowing of the space of this whole canal. So it means the canal is very small, it's around 3.5 centimeter long, very small canal is there in female. So in that urethra, if any inflammation can happen, which will create a narrowing of this canal. So means the passing out of the urine will be difficult for the female. And this can also show over distended bladder. So there will be more urine inside the bladder because the passage is not there, it cannot go outside. So this is some kind of incontinence things which we have to understand, that how the organs can affect the frequency and the amount, the dribbling or the force, all these things. And very important, the canal is going through the pelvic floor. Okay, so this is the pelvic floor, and if I just create a free canal for all of you, so just assume that this is a urethra. Okay, it's very long but small. This is a urethra, and the one side pelvic floor and other side pelvic floor. So pelvic floor muscles are like this. Okay, so in this, the urethra is going to pass through. So this pelvic floor is going to be the very important structure, which is through which the muscles are passing. So now this urethra is passing. So now if something happened with the muscle, for example, if the muscles will become very loose, so they will not create a functioning of the closing and opening. Sphincteric action will be less in case of that. So means pelvic floor, if it is very tight, very loose, so it is going to affect the functioning of the urinary system. If something happened with the organs, it is also going to affect with the urinary system. Same way, when we are talking about the other organ, like second organ we are having is very important organ, which is making us unique, that is a uterus. So if uterus, so during the pregnancy, expansion is going on, and there's too much of relaxation is going on, and when the childbirth is going to happen, labor stage 2, baby is coming out through the vaginal canal. So the uterus is having a vaginal canal, and vaginal canal size is the biggest size in all these three canals. So when we're talking about the size of this urethra, it is 3 to 4 centimeter. When we're talking about vagina, so it is altogether 5 to 6 centimeter. And when talking about the rectum, so rectum is a very small, 2.5 to 3.5. So all of these three, rectum is the smallest canal. But try to understand that what we are holding in the rectum, solid, something solid, weight is there inside the rectum. So that's why the muscles which are around the rectum, even there is a sphincters, internal sphincters and external sphincters, they are very strong around the rectum. The canal is very small, but the sphincteric action of the muscles are very, very strong around that area. Same way, the middle, so now the anterior is the urethra and the posterior is the anal canal. So what is in the middle? Middle is the vaginal canal, the longest canal and the more broadest canal. We are having some kind of rugae, some tissues of this vagina, which is making it more elastin. Okay, so they can expand. So whatever size we want to insert inside the vagina, if it is a small size of the tampon, or if it's a bigger size of the dilator, you can insert anything inside. Because of this, it is highly expandable in nature. It can grasp the size of the object. So this size I can penetrate, so it will grasp. If I will penetrate 3 fingers, it will grasp. So this much of elasticity is there inside the vagina. So means that hole which lies in the middle, through that hole, the center of gravity is passing. That is the biggest hole. And that hole means that vagina and the uterus, this whole middle part is going to support, the vaginal walls are going to support the anteriorly urethra and posteriorly rectum. So it is a kind of supportive system, this vaginal canal is, okay. But that when we're talking about the gravity and when we're talking about anything which is falling into the center, things will always come into the center. So center is vaginal canal. So all the intra-abdominal pressure, like for example, just give me a minute. So now anything which will come into the center, as per the gravity, there will be always a fact there. And that's why when we're talking about another word, which is very common, and you have brought it down also in the questionnaire, that the conditions which you are aware as a physical therapist is a pelvic organ prolapse. So means organs are going to fall down through the vagina, through the center, downwards. Okay, so the prolapse of the anteriorly, the bladder. So when there's a prolapse of the bladder, we call it a cystocele. The prolapse of the rectum towards this anteriorly towards the vagina. So that is the rectocele. When the uterus is falling down, this is the utrocele. And then we have if the female sometimes when they, after hysterectomy, when they remove the uterus, so upper side is always empty. Okay, so that space will be acquired by what? Small intestines. They will fall into that place. And that's more, and even some adhesion formation. So means weight will be always there into that empty space. And because of the weight, the intestines sometimes can start falling downwards. So that is another prolapse. That's the antrocele. Okay, so this is the 3: cystocele, rectocele, utrocele, and antrocele. Or sometimes, if not only the antrocele is coming out, sometimes the vagina itself, if the whole of the vagina is very big, so vagina can start coming outside. So that is a vaginal vault prolapse. So altogether there are 5 types of prolapse. So means the organs can fall down from the center. So this is again one condition which we are aware about. So if the organs are falling out, what can be the reason? Again, load from the top or gravity from the bottom. These 2 things can always affect this transversely placed muscle. Okay, and so this thing what can affect the female, and female can have the problem. Or what else can happen? Sphincteric action of the pelvic floor muscles. Sphincteric means closing and opening action. So now the same way the urethra was passing through the center, same way the vagina is also passing through the center from this muscle, okay, downwards like this is the vagina, okay, so these muscles are there. If something happened with the organ prolapse, it can create a strain over the muscle, or if something happened with the muscle, it can create a problem with the organ also, organ functioning. So now, for example, if the muscle is over tight, so means openings are not visible and very hard to relax this muscle, so penetration will not be possible. If penetration is not possible, so what will not happen? Fertility will not happen because ejaculation will not happen inside the vagina, isn't it? Vagina is the one part which is a part of reproductive system. So we need ejaculation inside. When this penis will go inside the vagina, assume this is the vagina and this is the penis. When the penis will go inside and after sexual activity, when ejaculation will happen near the cervix, then only that sperm will go towards the uterus and female will conceive. If there is no penetration, so means female will not get conceived, and this is one cause of infertility. Okay, so tight muscles, no sex, vaginismus, or sometimes female are able to penetrate the penis, but too much of pain female will experience during this penetration. So penetration is not possible, penis is outside, vaginismus. And if penetration is painful, penetration is possible, but it is painful for the female. Every time it is giving pain. So that is dyspareunia. So this is again some condition which is affecting many females. Even today itself from Australian society, I received a mail. They have shared some videos of some patient who are suffering from vaginismus. I will share with all of you. Please share your email address. So I'll forward that mail to you. So there are many, even I will try to share that video link on the group. So there are many patients who are suffering from either dyspareunia or vaginismus. So vaginismus means, you can understand, no fertility. Okay, female will not conceive. I have seen patient in my life, like 9 years of marriage, 3 years of marriage, never had intercourse. That's why they're not able to conceive. The society, they don't know why the female is not conceiving, because never penetration has happened. Many females are like, I'm attached with some hospitals also. So I have seen that I'm like regularly I'm seeing the cases in IVF hospitals that when the vaginismus is there, so doctors, the patients are going for IVF. They don't want, because ejaculation is not possible. So instead of working with the gate, opening of this gate, they just ignore that gate and they take the sperm, they take the egg, they do the IVF and insert it inside the uterus. So IVF is very common in that cases also. So, but as a physical therapist, we can understand that we can create a relaxation of the muscle. So this is what I'm going to teach you in this pelvic floor workshops, that how to work with that and how to assess those muscles. So that can happen. So means vaginismus, dyspareunia, or if the muscles are tight, or if the muscles are loose, so means prolapse. If the muscles are loose, so means no sexual sensations, less sexual sensations because proprioceptions are not there. Assume this is a vaginal cavity, okay, and this is a penis. And if penis will come inside, and if the female will not feel anything inside, no proprioception, no grasping. So grasping is because of the strong vaginal cavities, vaginal wall, as well as the strong pelvic floor. If the pelvic floor is strong, they will grasp the penis. But if they are weak, they will not create any tightness or any grasping. That effect will be not there. So female fail to feel the organs, and so she might, like 80%, 70% of my patients who I have seen so far, even many female physiotherapists also, because I have more than 500, 600 physios I came across with during these workshops. Even they always tell that after certain age, after certain deliveries, childbirth, they don't feel anything inside the vagina. So no feeling is because of no proprioception. So means again pelvic floor is responsible for that. Not only this, not only pelvic floor, even the vaginal cavity also, vaginal wall also, the muscles. But we cannot do anything with the vagina because vagina is made up with the smooth muscle. And they are not voluntarily, we cannot train that. They're involuntary in action, isn't it? So we cannot train them voluntarily. So whatever happened with the vagina, it happens for forever. But we can save the pelvic floor, or we can close the door for the prolapse by strengthening the muscles. And if the muscles are tight, we can create a relaxation of the muscles. Same way, when we are going towards the posterior part, we are having a rectum. So we can understand that it has a function and role, that it contains strong stool, solid parts, which has a weight. So assume if the pelvic floor muscles are weak around the rectum, so the leakage can start. Patient will not able to hold the gas, not able to hold this stool or the passing of the stool. So that urge will be there. So that kind of condition can happen. And if the muscles around the rectum are tight, it can give other conditions like constipation, one cause of the constipation, or pelvic dyssynergia, many other conditions, tightness, puborectalis muscles, they can, that spasm of puborectalis muscle, that can also happen. So no painful defecation, no defecation, hard stool, constipation, or urine incontinence, fecal incontinence, that kind of things can stay there. So this is the very small overview, but my why I want to tell you that pelvic organs can affect muscle, and muscle can affect the functioning of the pelvic organ. They are both correlated. And not only these are correlated, it is even the weight of the female. If there's a, like, assume that I'm a female, my BMI is normal, my muscles are good, whole muscle, whole body, I'm going for exercises. But how many females you are aware that they are doing this training of the pelvic floor muscles also? When the patient is coming to you, what we are doing, what we are checking, whole body strength, like we check the core, abdominals, we check the back muscle, we check the diaphragm, we check the all limb muscles. But have you ever checked the pelvic floor? No, which is very important, the transversely placed muscle. This is the only one muscle which is kind of, placed like this after this diaphragm. So diaphragm is there, it is not directly in contact with the gravity, but the pelvic floor is in direct contact with the gravity. Okay, so this muscle really need a good amount of training every day, or at least 3 days in a week. So in all the cases when I'm fit, so I should definitely go for minimum 3 days a week training. If my pelvic floors are over tight or over loose, so might be more sessions I required. If because I'm not normal, something is bothering me, something is bothering my quality of life. When we're talking about pelvic floor muscle is a kind of talking about that area is a taboo. No, we are not comfortable. Not all the females are comfortable discussing about this problem. So now, but what is important is that, yes, the muscle is there, it has a function. If something happened with it, it is going to affect the quality of the life of a patient. So now let's try to understand the organs and the muscles. This altogether might be 16 hours we are going to spend into workshop, or 18 hours starting from 9 o'clock up to 6 o'clock. Okay, in the evening. So every day, 1 hour we are going to use into lunch and this kind of things, isn't it? And so like still minimum 15 hours we are going to spend with each other. When we're talking about this pelvic floor, so we don't know how to assess this muscle. We don't know what is the function of this muscle in that clarity. We don't even know about the anatomy of this muscle clearly. So, and the organs is also there. So this is a kind of ocean when we're talking about this area. And I normally believe that 15 hours of online training, just the understanding of theory, and 2 days of intensive training makes some justification about the learning of this muscle. But what I can do, just to make you more clear, because every time I'm going for workshop, every time I feel satisfied when I give best to my colleagues, my friends. But sometimes I always believe that no, I can share more because there is more into me. So how to share that more? After finishing this workshop, I will add you in a group we have a group of this whole India pelvic floor PTs, which I have trained so far, and we have a continuous discussion about the cases, patients going on. So that will be a learning process for all of you throughout the life. Okay. And the second thing is, like, if you have taken my workshop, pelvic floor workshop, so whenever I will have any online class about pelvic floor, so there will be always that pamphlet or something you might know. So you can send me just a simple message, ma'am, please add me in the group. So you don't have to pay, and you can revise the pelvic floor as much as possible. So because every patient is teaching me something new. Even the last time I went to Chennai, and there was a very good question. One girl, she asked me, and no one asked me in last 7 years. And so every patient, every time there is a learning. She asked me, what is the antagonist of pelvic floor muscle? So, oh yeah. Surprise, it's kind of new things for me to learn also. So every time when I learn something, I always try to put into the group also. So the learning will be always continue. And but what is clarity? What is important? That you all should have right understanding about, right knowledge and complete knowledge about the functioning of the organs, how the organs are functioning. So what is the bladder, what is the anatomy and physiology of the bladder, what is uterus, what is the rectum. So whenever you have a time, keep reading about that, and I will keep sharing the things with you. I will give you some clarity, but might be 50%. I will try to give you my level best, but always, whenever you have time, try to learn more about the organ functioning, the nerves, nerve supply, how they are affecting the firing of the nerves. Many things are there. And not only the organs, but the problems which affect this organ, what is the pathology of the organ, and how it can affect the pelvic floor. So that correlation. And if, again, about pelvic floor, I will teach you everything. So I will share some list of some conditions with all of you. And for example, simple interstitial cystitis. So you should be understanding that what this word stands for. Vulvodynia, vestibulitis. So when this is sometimes when the doctors will send you the patient, they will write down in the files. It will be written into the files that the patient is suffering from this problem. So you should be able to understand that also. So all the condition which is which is related to that pelvic organs, that should be the part of continuous learning. Always there is something new. Many researches are going on throughout the world, like up to 2015, 16, 17, 18. I was not aware about this posterior tibial nerve stimulation, okay, which we can do as a physical therapist with our simple TENS machine, electrical stimulator. Okay, and that has a very big role to play in a role of urge incontinence. So I will teach you that also. And now there is other, there's a femoral arterial compressions are there, some pudendal nerve compressions are there. Always the world is doing more research, more authentic research, and that will be all over the continuous process, learning process. So now today, let's try to understand the anatomy of pelvic floor muscle. I read many books so far in my life, and all the books, there's no standard book which is going to give you a one fixed right answer when we're talking about the pelvic floor. So pelvic floor is not one muscle, it is a network of muscle, but how many muscles? Very recently, I read a book about pelvic floor, and it was written in that the pelvic floor is a group of 17 muscles. So 17 muscle. So then I was surprised that 17 muscle, because I'm working in this since many years. And what I know so far is there are superficial layer, there's a deep layer, and there's a middle layer. And there are some muscles inside that part. And then I again went to my whole, muscles. And then I realized, yeah, there are 17 muscles. So there's small muscles in the pelvic floor, which is a net. So that pelvic is a network of muscle. So there is not only 4 muscle, 8 muscle, 5 muscle, altogether 17 muscles, which is forming this network, big network, and this floor. And the muscles fibers are coming from this angle, this area, just to create the complete boundary. So close the boundary. Okay. So you might be so far understood, the pelvic floor is a supportive muscle. Pelvic floor is a sphincteric muscle. Pelvic floor has a role in sexual functioning as well. Pelvic floor has a role in pumping, creating circulation around this pelvic area as well. So it's the muscle of which is creating this lymphatic drainage is going on, the circulation is going on. So muscle of circulation. And the pelvic floor is very, very important muscle, which is going to give you support, sphincteric action, closing and opening, and this lymphatic, this circulation, and sexual. So all these 4 or 5 functions are there of pelvic floor. So now let's start. I'm going to share one PPT with all of you. Be with me. And can you see the PPT? Please let me know. Yes, is it visible on your screen?
Yes, ma'am.
Yes, ma'am.
Great. So these are the topic which every physiotherapist or pelvic floor therapist should be aware about. Anatomy, physiology, and function of pelvic floor organs with respective canals. You should understand the bladder, urethra, prostate in male, urethra in male, uterus, vaginal canal in female, urethral sphincters. There's external sphincters are there, rectal sphincters, rectum or anal canal. Anatomy and physiology of the pelvic floor muscle and the function of pelvic floor muscle. What is this micturition process and the pregnancy effect of internal pressure, gravity, the role of nervous system into the micturition, very, very important, because when we're talking about urge incontinence and when there's some neurological incontinence, involvement of nerves are there. So we should also understand that as well. And what happens with this functioning of something affect the functioning of the pelvic floor. So we call them as a common pelvic floor muscle dysfunctions. When the muscles are weak, legs, we name it as a hypotonous pelvic floor muscle. And when there's a weak, so means they are going to lose this effect from this sphincteric area. So it will give us it can give us urinary incontinence, prolapse. It can give us vaginal laxity, some flatulence, fecal incontinence. Or if the muscles is very tight, we are calling it as a hypertonous pelvic floor muscles. And tight muscles means it will create a compression around these openings. So means opening will be painful. So during the urination, female will feel pain. During the defecation, female will, not only female, patient will feel pain. Even during sexual intercourse, patient will feel pain. Or because of this continuous pressure, the compression and the tightness of pelvic floor muscle, the fascia and everything will be tight, which will create a more compression around these pelvic organs also. So whole pelvic organs, the pelvic cavity will have a tightness. So the pelvic pain will be also there in a patient. Interstitial cystitis, chronic pelvic pain, vulvodynia, vaginismus, dyspareunia, constipation, hemorrhoids, all these are the types of hypertonous pelvic floor muscles. Sometimes one fact is a universal fact that whenever one part is open, other 2 parts will be shut off. For example, if you are going for urination, same time you are not going for sexual activity, and same time you are not going for passing of the stool. Yeah, defecation, passing of the stool. So means one time one canal is open and 2 canal are closed. If you are going for defecation, now the vagina and the urethra will be closed. If you are going for sexual, so means urethra and the anal canal will be closed. So never 2 are function at one time. But sometimes a problem can happen in a case of a patient who are suffering from constipation. If I'm suffering from constipation, so I will have this habitual pattern of voiding pressure, okay, just to, during the defecation, because stool is hard, tight. So during this voiding force which I'm applying, so that force will not only apply around this posterior aspect of pelvic floor, that force is going to transfer around this anterior aspect also. Anterior muscle also. So this more voiding force or more internal pressure, if you are applying at the posterior aspect, that can create a weakness of anterior compartment of the muscles. And that person can have a leakage of urine. So one patient can show you two things: leakage of the urine from the urethra and the tightness around the rectum. So when the two things are present in the same patient, so means this is a mixed pelvic floor. So our pelvic floor is like the incoordinated pelvic floor or mixed pelvic floor condition. Now let's go to so this is the pelvic floor dysfunctions, some name. When we're talking about the rehab as a physio, so we should understand about some guidelines, because this muscles are present at a very sensitive place. And talking about that, so when you are going to have this selection of words, when you are going to counsel your patient, the selection of words is very, very important. That how you are communicating with your patient, how relaxed, how much comfortable you are making her or him to feel. And so that is very, very important. Patient guidelines, education, counseling, that things matters a lot when we're talking about pelvic floor, because we are not talking about the physiological condition of the patient. That physiological problem is affecting her psychology. It is affecting her quality of life. If you talk about, like for example, she's suffering from vaginismus or dyspareunia, she's having a sexual pain. Well, let's not talk about sexual pain. Let's talk about the urinary incontinence. I'm not comfortable if I'm having this incontinence. I'm not comfortable in front of you sharing this very, very kind of personal thing. So that is a kind of, they will feel shy, they will not share with you. And that's why it is our responsibility that we have to have this understanding and knowledge about this system and the selection of the words. So what kind of counseling? So means we are not talking about the physiological fact, we are talking about the psychology. Whatever, they will not come to you if they will not like your, this first session. So first session is very, very important. And that will be good session if you have a more clarity about the pelvic floor. And we have to understand the person who's sitting in front of us also at that time. So patient guidelines, what is the procedure to proceed? Because not only this external visual observation and some external palpation we are going to do, it involves internal palpation. So sometimes we have to insert our finger inside the vagina, insert our finger inside the rectum. So that is upcoming procedure which you are going to follow in the pelvic floor assessment. So the patient should be comfortable. Please mute yourself. Hi dear, please mute yourself. Patient guidelines and procedure is also very important. I always believe that this is the one change which came in my life when I started pelvic floor. I started loving the female more. I understand them. I feel that the problem is not, she's not going through the problem, I am going through the problem. So in that way, we have to become their mirror. Okay, so this is a kind of mirror counseling. So the word which you are comfortable to hear, you should use with the other person. So that is always, I believe, and I follow in my practice, that understand the female who is sitting in front of me. And it is not easy for her to come all the way and sitting in front of you and discussing her very private and personal issues. So respect always. Now, after this counseling and this understanding, this whole guidelines, next thing is we as a physical therapist should be very thorough with the assessment and the examination of all this area. So this area means what area? Not only this perineal area, but abdomen also. So this abdominal muscles, they might be tight. Because of the tightness of that, there's a tightness of pelvic floor. So the palpation and assessment of abdominal area, the genitals, external genitals. So this is a whole perineal body is there, perineal area is there, vulvar area is there, rectal area is there. So this external genitals and internal genitals like vagina, rectum is also there. Pelvic, so we should be thorough with the assessment and the pelvic floor muscles. So pelvic floor muscles, what are the superficial muscle, which muscle you can palpate, which muscle action you can observe outside, which muscle action you can feel inside. You cannot observe inside the deeper muscle action, but you can feel that on your finger, and that feeling comes with the practice. So if you just palpate yourself, so this is only you are familiar with your pelvic floor muscle action. So for more understanding, you need to go for more palpation. So that's why workshops are very important, and these workshops are going to give you a kind of exposure of some vaginal, like you will go through the palpation of many other females' vagina. So if you'll come to my clinic, I'll do everything on you, and you feel yourself. But you have to feel the patient. So you have to have that confidence of palpating more vaginas. So after palpating 5 vagina, you will get a confidence. Okay, so that's why if you really want to become a very good pelvic floor therapist, you have to palpate more and more vaginas. You should be familiar with the more and more structures of a female. So it will give you more confidence. So during this practical sessions, very good advantage we are going to have is that we will be around 14 girls, and all, so means you can have a group of 4 or 5 girls, and you can palpate on each other, and that exposure no one will give you in life, because no other that kind of chances you will get. So more assessments you will go through, you will get through this kind of workshops. So more palpation is important. And now after palpation, there are some universal examination of this through this external muscles, external surfaces, internal palpation, internal examination, into the rectum, into the vagina. Everything should be kind of feeling. You should have maximum feeling. And after this, you should be aware about some very valid, authentic scales and the assessment tools and some guidelines you should follow. This kind of, we need documentation for everything. So that is also very, very important, which I'm going to share one assessment form that is like, I will share with you in the group just 2 days before, 1 or 2 days before the workshop. So take a printout of that and bring that on the workshops, go through that. This is a very, very, that if you go through that form, you will be clear with the assessment. So I designed it, and just to make it more clarity, give you more clarity. So depending upon how many assessment you want to do, how many palpation you want to do in the workshop, you can bring that many copy, 4 copy, 5 copy, as per your, just it is depending upon you. So you have to fill the form for each and every person. So if you go through this assessment thoroughly, so means not only one form, 5 form you are going to fill for the 5 patients. So we'll be more confident after that. And after having this assessment, very important, the treatment. Patients are they are going through this problem. It is affecting their quality of life. Now, how we can help? How many sessions we have to plan? What are the therapies? Manual therapy, electrotherapy modality, exercise. This is also very, very important. Very, very important, which I'll give you clarity. And next one is a lifestyle and behavioral therapy and training about posture guidelines, breathing pattern, bladder diary, bladder retraining, neck technique, bed test, dietary support. This is also very important. Home exercise plans, tips for helping bladder to empty, nighttime voiding, post-void dribbling, uses of topical estrogen in case of post-delivery, just a postnatal time period, or premenopausal or postmenopausal when estrogen is not there, because estrogen has a very big role in the skin and the muscle health. So whenever the estrogen level is going down, there will be always weaker areas, weaker muscles and structures. And prevention of urethral and vaginal infections. So it means not only this pelvic floor, but the hygiene female has to maintain plays a very big role, because many conditioned females are suffering from this area is because of the infections. So if there's an infection around the urethra, she might have this interstitial cystitis or some other issues, inflammation inside the this whole tract, renal tract, or if she's having infection into the vagina, so there will be always pain into the inside the vagina, or feeling of pain during the intercourse or penetration. And that infection can go towards the cervix, passing through the cervix, it can go towards the uterus. So infection, it can create other issues also. So infection has a very, very, very important role. So female hygiene, depending upon what structure you have seen, you have to show that, you have to give that kind of guidelines to the female. So no, there's no fixed protocol. Every female structure, as per the structure you are seeing, as per the findings, you are going to give her guidelines. So the guidelines are tailor-made, customized guidelines for the patient. So now, let's start our session. Pelvic bone, we all are very aware about this structure. So the landmarks which we have to be like very clear is the pubic symphysis. Okay, so this is the pubic symphysis here. And anterior superior iliac spine, iliac crest is there all the way. This is sacrum posteriorly. This is the tailbone, coccyx. And this is ischial tuberosity, both side 1 and 2. Let me take a pen. This is the ischial tuberosity. And this is pubic symphysis. This is the tailbone. Okay. So now, I want all of you to do the palpation, self-palpation or on your body. Right now, please palpate your pubic symphysis. Palpate your tailbone. Do this exercise with me. Palpate your ischial tuberosity. Okay, so these are the 4 landmarks. If you join all these together, so even right now you can sit on a piece of paper, one simple A4 size paper. If you sit on that and you will mark, after palpation, you will mark that 4 points on this paper. And if you join them together, you will get your pelvic floor. So this is the area where your muscles are present. All these areas are pelvic floor muscles. Okay, so these 4 landmarks, so this is the pelvic floor muscle area. There are 4 ligaments which is present here. Very beautiful image. Posteriorly, we are having posterior sacroiliac ligament. So sacrum and this ilium is joined with this. We are having ilioinguinal ligament. Ilioinguinal ligament is very important if we are going to work with the infertility also, because this it is a very good landmark for this where the these organs are present. So this is a inguinal ligament. So one side superficial this pubic symphysis, and ASIS if you join, this is the inguinal ligament. And this is a pubic ligament, connective tissue, and this is a posteriorly sacrospinous ligaments. Ischial spine and sacrum, it is joined by this yellow. So 4 ligaments are present there. And during the pregnancy, this relaxation of these ligaments are also going to happen. Ligaments are important for the stability. And if the ligaments are lax, loose, weak, so stability issues will be there. So the pelvic floor is a very good, very important muscle for the stability as well, because it provides stability all the way from this pubic symphysis to the sacrum. The muscle is coming like this. So it is a muscle of stability from the ischial tuberosity, right side to the right side. The muscle is going to connect. So this is a very important muscle of the stability, which provides the stability of the area. So ligaments are important, the muscle is important, and so the organs, the pelvic organs, so palpate your pubic symphysis. Once you palpate it, behind it, if anyone of you are feeling like, if your bladder is full and if you are feeling like this urinal sensation, so if right now, if you palpate your pubic symphysis and one finger on the top of that, so pubic symphysis, one finger on the top, if you put a downward pressure, so this will be the kind of filled bladder you will feel. So more fullness of the bladder you can feel here, and that palpation and this deeper palpation will increase the frequency, increase the feeling of urination. Right now you can do it on yourself. So this is present behind the pubic symphysis, and with the respective canal, this is a urethra. Same way, we are having this uterus, and on the we are having this cervix of the uterus, neck of the uterus, we are also calling it, and the posterior to the bladder, we are having this upper part of the vagina. Look, this is the upper part of the vagina, and the lower part of the vagina is present behind the urethra. Okay, so behind the urethra it is present, and behind this vagina we are having this rectum. Whole rectum is present. Some lower part of the rectum is present, and out of this whole three canals, you can see that the biggest canal is vaginal canal, and the smallest canal is this anal canal, very small. Okay, so this is smaller canals, and this whole red color of surface, which is on the one side, you can see is the pelvic floor muscle. So where pelvic floor is lying exactly at the lower 1/3 of the vagina, you can say. So this is a vagina, and lower 1/3 of the vagina, or crossing this urethra, or by creating an uncircling around this rectum also. It is going from anterior pubic bone to the posterior side towards this coccyx. So now this is the right side of muscle, same way, the cross-sectional image. So same way, there will be left side of muscle. So very big muscle it is. So these organs are somewhere lying on this muscle. So they are supported, they are resting on the muscle, which is, so that's why it is supportive muscle. The canals are passing through that. So it is a sphincter, it is working as an opening and closing around the canal. Sphincteric action is there. It is going from the anterior to the posterior. So stability is also be there because of the muscle. Right distal tuberosity to left distal tuberosity, stability is going to be there. And other thing, as I told you, sexual and the lymphatic circulation of that. So this is that organs. Now here, very important, please try to join me for infertility if you are interested, but you should understand the palpation of your organs, reproductive organs. So palpate your ASIS, both sides, palpate your this pubic symphysis. Sorry, this is the pubic symphysis here. Okay, so this is the pubic symphysis. And from here to all the way other side, we are having inguinal ligament. Okay, in the middle, this is inguinal ligament. So if you cross this inguinal ligament into, if you divide it into half, so this is half of the inguinal ligament, and the lower half, like this area, again divide the lower part into the, again, 1/2. So this lower part is where your ovaries are present, both sides. So this is the way you can palpate your ovaries, right? Left ovaries, and the same way on other side, divide it into half, and then other half. So this is a third, fourth area. 1 or 2 finger deeper, more deeper. So
Ma'am, can you please repeat the palpation
let
of
me
ovaries?
show you. Let me show you that. Okay. Right now, you palpate your, all of you palpate your distal tuberosity. Okay. Sorry. ASIS, and they palpate your pubic symphysis like this. The patient should be lying supine and a bit one below, beneath the hips. So it will be kind of upper. We need some kind of elevation, and then palpate the ASIS and palpate the pubic symphysis. So this is my pubic symphysis. This and this. Okay, this is the edges, tubercle. Now this tubercle to this. So this is the area where my inguinal ligament is there. So now this inguinal ligament, for example, this is an inguinal ligament. This is the black. Okay, so this is the inguinal ligament. So now this inguinal ligament you cross into half, cut into half. Okay, divide into half. So now forget the upper part. If you are walking into reproductive pelvic pain also, when the patient is going through pelvic pain, so the lower half is very important for you. So this lower half now again divide into 2 parts. Okay, when you divide into these 2 parts, so this part is important. This part. Okay, this part where your ovaries are present and they are almond shaped. So now if this is the inguinal ligament, palpate your bony structure, the ligament, and then put your finger like this, one or two fingers like this, and go one finger away from the inguinal ligament. So the one finger away, so this is the distance of approximately. So if this is my inguinal ligament, this is my inguinal ligament, all of you can palpate right now and just leave one surface, one finger distance, and put your finger, put downward. When you press downwards, so there will be kind of 1 or 2 centimeters. If you are a kind of thin body, 2 centimeter down, you will feel a small almond shape of organ. So that is your ovary. And that is swollen and painful if the female is having cyst, ovarian cyst in case of PCOD. Okay, so that pain will be there in case of PCOD. So I want all of you to just, if possible, palpate yourself today, or try to palpate every day and show me on that day, because I'm going to show you that palpation on that day also in workshop. The second is very important, is to note down that where is your uterus. So for uterus, again, palpate the pubic symphysis. Okay. So this is the right and left tubercle. So this is the whole, this my one, and this is my navel. So put your both thumb over the navel like this, because every female is different. Your hand length is different. Your body is different. Put your both thumb over this navel and join your index finger. And where you are joining the index, put the index finger downwards here. So where you are joining this index finger, this is the area where your uterus is present. Okay, like this. And now join this and then use your other middle finger and pressure. If you put this pressure right now, you will, if you put a pressure, like I'm putting a pressure, I'm feeling something is coming inside the vagina. Some feeling will be there. And during bimanual examination, this is like, you know, you are trying to push it downwards. During bimanual examination, when your one finger is inside the vagina and you can touch the cervix, and from the upper side, if you put a pressure, you will feel the movement of the uterus on your finger. Okay, so this is a bimanual examinations are also there. So we will do it on the workshop also. So this is the area where your uterus is present. And in case of C-section, you know, after C-section, when there's a scarring is there, when there's maximum chances of having adhesion formation, isn't it? After every surgery, adhesions are common. And adhesion is a one very big cause of infertility, female infertility. And it can affect the vascularity of this uterus. And so now we as a physical therapist, what we can do, we can help our female in better healing, and we can help our female in reduction of the adhesion formation. So adhesion should not happen there, or create more vascularity around the uterus, because all the organs, they are lying there. I'm a uterus, I'm there with my ligaments into this pelvic cavity. Okay, you are bladder, someone is rectum. Everything is mobile in nature. When I, like as a vagina, I need expansion during intercourse, penis is coming inside, so vagina is expanding. So when where vagina will expand? Downwards? No, upward, isn't it? So when it will expand upwards, so the cervix will move, the uterus will move, it will move towards the abdominal cavity. So movability, mobility is very, very important just for the functioning. When the rectum is full, you know, so at that time, the rectum needs space. Will it will move posteriorly? No, it has to move anteriorly. So it will put a pressure over the vagina and uterus, isn't it? So it needs space. During the filling of bladder, it needs space, so it will move posterior. So all these organs are highly mobile in nature. So we don't need tightness into that area. So if the muscles are tight, the fascia will be tight. If the fascia will be tight, it will touch with the muscle, the organs will be feeling that tightness, isn't it? And that will go, the mobility will be affected. Other case, if there's a C-section, baby came out, there's many healing has happened, stitches are there inside the uterus, they stitch the uterus, the fascias, and then there's a fat and the subcutaneous tissue and skin, everything, there is a stitches, many layers of the stitches are there. All the layers, there are chances it is going to give adhesion to the patient. And because of that, depending upon where adhesion means low vascularity. If vascularity is altered, if this is my uterus, and there was a cut over here, okay? For example, fundus or around the isthmus, there is a cut. So that area, try to understand the inner side of the uterus. So this is the outer side of the uterus, and this is the inner side of the uterus. The cut was there. So that cut, adhesion means low vascularity. Now, next time, when the female will go for pregnancy, or the endometrial layer will not happen in this area because vascularity is less. Or she might feel problem, or even during the implantation, the placental formation, because this area, if the egg will move here, fertilized egg, it will not get vascularity. So it will not, implantation will not happen here. So it might move some other area, other way into the uterus. This is the one cause of low-lying placenta, placenta previa, because there's a damage to this wall. So that's why adhesions are very, very problematic. And this scar tissue formation, adhesion is there. Now try to understand if that scar happened around the canals. There are two canals, fallopian tubes, one side, other side. Into the fallopian tube, egg is waiting. Fertilization doesn't happen in the uterus. It happens inside the fallopian tube. So the sperm has to move all the way there, isn't it? But if the canal are blocked because of this adhesive tissue or this scar, again, fertilization will not happen. So it is a cause of infertility, adhesion. That's why many female after C-section, they are feeling difficulty in pregnancy again. Okay. So that's why we have to understand all this organ functioning. Some females, they are suffering from endometriosis. If endometriosis is there, the problem will be into the uterus. The endometrial tissue will be all there, which will start creating adhesion. There will be spasm inside this uterus. That spasm will fall into the fascia. The fascia will be tight. The muscle will be tight, and painful defecation, painful sexual intercourse, painful, urination. Everything can come into picture. So we need mobility there. High degree of flexibility there, and which is there because of the ligament, and I should be free to move in my room, my space. So no tension. I don't need any tension. I don't we don't have to put any tension, but that tension can be there because of any surgery and the scar and healing during the healing process. So very, very important. So let's go to the yes. So bladder, I will explain you on the day of workshop, but if you have a time, please take a screenshot and read it. I'll explain you in a more detailed way because it is very important to understand. Urethra of female and male, take a screenshot. We will discuss on workshop. Micturition process, we will discuss in workshop, but please just read it if you have a time. This is not important for today. It is also not important for today. I'll teach you into the workshop. I'll teach you into the workshop. In a workshop, let's understand the pelvic floor anatomy. If our complete pelvic area is behaving as a wall or home where our pelvic organs like bladder, uterus, rectum, and prostate in male, they are lying, then the pelvic floor muscles are the base, floor, and foundation of that home, which provides a strong base of support and opening to all respective canals or organs. I want all of you to please see your structure today. Take a mirror and go to the washroom and see your structure. You should be familiar with your own external genitals. So when we're talking about this area, I'll explain you all this onto the day of workshop, thoroughly. But that is very important. So this is when you ask a female to open that area and you are looking at that area. So some things which you are going to see there is first will be the hair all over. Okay, so the hair, like on the top of the pubic symphysis, you will see the mons pubis, which is where there's a cluster of hairs are present. Now on the both side, on this groin area downwards, you will feel this is a labia majora downside, and labia, on the labia majora also there will be presence of hair all the way downwards, labia majora. And after labia majora, you will get more internal one flap kind of petals, two petals are there, skin flap, that is a labia minora. And where the labia minora joining at the bottom, so labia minora, if they are joining at the bottom, they're starting from the bottom, this from, look, this one is a labia minora. It is going up, 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 and going up here. It is ending here. This is the one side and this is the other side. So this is a two labia minora, folds are there. And the lower part from where it is starting, we are calling it as a vaginal fourchette. I'll explain you in the workshop also, vaginal fourchette. And this upper part where they are joining with each other, they are creating a hood of the clitoris. So our clitoris is present here as a female. Clitoris is our sexual organ. Vagina is not our sexual organ. Our sexual organ is clitoris. Vagina is a part of reproductive system. So now this is a clitoris, and this labia minora is creating a hood of the clitoris. So means because it is an open structure, the glands of the clitoris is highly sensitive and we don't want any direct touch onto that. So that is always hidden inside with the help of this extra fold created by labia minora. And now once you will see, there is a one very soft, smooth, shiny structure inside this. This area is called as a vestibular area, vestibule of the female, this whole pinkish part. So now we also name it as a lips, vaginal lips, you can say. This another name of the labia minora is the lips of the vagina. These are the same, you can say that we are having these lips. Okay, so if you open, so assume lips is a labia minora. If you open, this will be smooth, shiny structure. The smooth internal, which you can see, is the vestibule of the female. It is one part of the external genitals. In that vestibule, we have two openings are present. So now, sometimes one condition which gynae will write down, vestibulitis, it will be written into the files when the patient will come to you. Vestibulitis means inflammation of this part, internal part, okay? After opening up the labia minora. If it is written, please mute yourself, everyone. Hi, please mute. Richa, it was you, dear. And this is a vestibular area, and the vulva is all the part from this, which is covering the mons pubis, labia majora, up to the down. So this labia majora and mons pubis is a vulvar part of the female. So if it is written that vulvodynia, so means pain into this area, okay, this area, all this area, external area. And if it is written vestibulitis, so means inflammation of this vestibular inside part, okay. And if it is written vaginitis, so means inflammation of the vagina. So I'll explain you all the structure on that day in thoroughly. And we have this lower, there's an anus, and in this vestibular area, we have a urethral opening and it's a vaginal opening. And the two openings are present. And the downward is the anal opening. Three openings are present into that downward part. So urethral opening, vaginal opening, anal opening, and the clitoris, sexual organ. 4 organs are very, very important for us. So we are going to see. So you have to see your ones. Try to observe your structures, your clitoris, your urethral opening, your vaginal opening, your anal opening. And once you will remove this structure, and this is part between the vaginal opening and the anal opening, this middle part is a perineal body, very important for all of us. It's a perineal body. So once you will remove this structure, the skin. So now in this picture, you can understand the skin is not visible. So at that time, you will be able to feel you will be able to see the action of the muscles. So this is the pelvic floor muscle. And I will ask you what is wrong with this muscle, this image. Something is wrong here. And, but in this pelvic floor muscle, when you remove the skin, so we will feel something like that. Let's understand that muscle today. So pelvic floor muscle are the group of muscles which are working together to perform its function more efficiently. It is a hammock, bowl, diamond-shaped muscle. So now, 4 landmark: pubic symphysis, ischial tuberosity, right and left, and coccyx. When you join all of them with each other, the corner of the diamond, so you will get a diamond shape. So that's why they're calling this muscle as a diamond-shaped muscle. Anteriorly, it is like this, yeah, the pubic symphysis, posteriorly coccyx, and laterally both tibial ischial tuberosities are present. So this is the diamond-shaped muscle. And if you take this diamond and try to feel your ischial tuberosity, so from one ischial tuberosity, draw a line and join both ischial tuberosity with each other. Okay, so this is the ischial tuberosity. If you are joining it, so this is the middle part of this. So this is a perineal body, perineal part. And the part lower than this, then again you divide this triangle, this diamond into 2 by creating a straight line from ischial tuberosity. So there will be division of this diamond into 2 parts, upper part and the lower part. Upper part where there's a urogenital, means urethra is present and genital organs like vagina is present. So we named it as a urogenital triangle. Can you understand that this is forming this a triangle shape? So if you draw a single line, and now from here, ischial tuberosity, follow all the way up to this pubic symphysis and draw another line and come downwards. So this is a triangle. And the name of this upper part is a urogenital triangle. Okay. Same way, if you draw a line from the center, ischial tuberosity, go downwards, coccyx, and then other side. So this is an anorectal triangle or anal triangle, where anus is present. Okay, so rectum is present. So the middle part is the perineal body. So now, which muscles are present into the pelvic floor? Many books will tell you there are 2 layers, some will tell you there's 3 layers, there will be some endopelvic fascia. The name of the muscles will be different in different books, but doesn't matter. As far as you are having a clarity about the muscles. So pelvic floor muscle has, as per my understanding so far, it has 3 layers. The outer layer is a superficial layer, then deeper layer is a deep layer, and there's a middle between both of them. There's a middle layer. So now let's understand the superficial layer first. So now once you will draw a line from ischial tuberosity to other side of ischial tuberosity, so one muscle is, this muscle, what is wrong in this picture is, this should be like this, downward should be downwards. So let me tell you 3 names of the urogenital triangle first, so you will understand. So now, yeah, over here. Ischial tuberosity one side and go for division, other side. And pubic like this, upper side, and other side, other, like this. Okay. So now, from this center, perineal body, this is perineal body, one muscle is originating. The name of the muscle is a superficial transverse perineal muscle. It is coming from the perineum. It is a super present and transversely present on the sides. So from this center, perineal body, the muscle fibers will go origin is from center of the perineal body, and insertion is inside this ischial tuberosity. So means this muscle. In this picture, this muscle from here and all the way ischial tuberosity. So this is a superficially placed muscle, transversely placed muscle, and perineal muscle. So superficial transverse perineal muscle, we call it STP, one muscle of the superficial layer. Second will be from the ischial tuberosity, one muscle will originate all this ischial span. It will go up for all this, and this muscle fibers will keep originating and going towards this clitoris. The muscle is insert origin is from the bony prominences and ischial tuberosity, and insertion is into the clitoris, glands of the clitoris, body of the clitoris. Sorry. So this is the next muscle. The name of this muscle is a ischio, because it is coming from the ischium. So ischio and cavernosus, caves. So these are the caves. Can you see? This is the these canals are caves. So ischio cavernosus muscle, IC. Okay, this muscle is. So this muscle, the superficial transverse perineal, right side, and then left side. This is a muscle of stability, which provides the stability of the pelvic floor area. And this ischiocavernosus, because it is going towards this clitoris, and can you see this? These are the legs of the clitoris. These are the legs of the clitoris. So it is covering the sexual organ. So these muscles are the sexual muscle of the of us, even in case of male and female both. So ischiocavernosus, this is the second muscle. And the third muscle is origin is from this pubic, this perineal body. The origin is from here, and the insert, it will go upward. The insertion is towards the clitoris. So this is again another muscle, right side muscle, like this, going upwards. And it is covering the bulb. This area is the bulb of vestibular bulb, which is present inside this external surface. I'll explain you on this workshop. So it is covering the bulb and is going upward. So bulb, bulbocavernosus, bulb, because the vestibular bulb is there and caves are there. So bulbocavernosus is the third muscle. So right side, and then there's a left side muscle is coming upward. So bulbocavernosus muscle. So the function of the bulbocavernosus muscle is again sexual function, because it is going towards the clitoris, insertion is there, and its other function is the, because it is present around the orifice. So this is the vaginal opening, clitoral opening and vaginal opening. So look in this picture, this is the urethral opening here, small, and this is the vaginal opening. The muscle which is present here is a bulbocavernosus muscle. So this is it has a sphincteric action also, closing and opening. So during the opening, it will move outward, and during the closing, it will move towards the center. So these are the three muscles. Let me revise you again through the image, through this image. So from here, center to the ischial tuberosity is the superficial transverse perineal. Sorry, this image is wrong. It should be like down like this. It should be like this. This is a right image. So this is a superficial transverse perineal. This is the ischio, is from ischium to cavernosus, to the glands of the clitoris, body of the clitoris. So ischiocavernosus, and this is the bulbocavernosus. So these are the three muscles of which triangle?
Urogenital
Urogenital
triangle.
Yes. So this is the urogenital triangle. Superficial transverse perineal, ischiocavernosus, and bulbocavernosus. And in anorectal triangle, it's only one muscle is present, that is a external anal sphincter. So muscle is coming, origin is from this center, again perineal body, and it will go and encircle the canal, like anal canal, and it will go and loop around like this, one side and then left side, it will go on other side. So this is a external anal sphincter. Sphincter means sphincteric muscle. Around the openings it is present. So this muscle is very, very big muscle. The width of that is very strong. So in this image, you can see that this is the whole, this width is this external anal sphincter. This is the one muscle of the superficial layer. It is very deep muscle. In this image also you can see it is a quite width of the muscle. And the muscle fibers around this, the whole three muscles, because it is very important to understand the direction of the muscle fibers, because sometimes in vaginismus and dyspareunia, there are trigger points which is present into the superficial layer. So now if in this picture, yes,
so this external anal sphincter, this is a part of the superficial muscle group only,
yeah,
right?
Yeah.
But only in the posterior triangle, right?
Yes, yes.
Okay. It is not a deep muscle.
No, it's a superficial muscle.
It is a
External
superficial.
anal sphincter
Okay.
is a superficial.
Okay.
Yes. So it is a, so upper part, there are three muscles, BC, IC, STP. And lower, there is a one muscle, external anal sphincter. Clear, everyone?
Yes, ma'am.
Okay. So now in male, if you will see this muscle, because you should also understand what is going on into the male body. So this is a kind of real image. So you can see from ischial tuberosity, now here, the muscle is going upward all the way, and this is the penis. So this is, I removed it because of the, I don't like to see that image. Just to be very sensitive image is that. So this is the penis going on up, upper side. So assume that, so now in this penis, the muscle is coming from the ischium fibers are going upwards and merging is into the body of the penis. So this is the body of the penis. The fibers are merging. Same way, muscles is coming from the center and going into the ischial tuberosity. This is the IC muscle or STP muscle, superficial transverse perineum. And now bulbocavernosus is split into two parts in our body. But it is as a whole, this whole muscle which is going into the base of the penis is the bulbocavernosus muscle in a male. Very strong muscle. It has a very big function to do in a case of male. It has a because they are going towards the sexual organ. So ischiocavernosus and bulbocavernosus are the sexual muscle in male. And why there is the muscle is split in our body and it is not split into male body? What is the reason behind that?
Sorry, ma'am, please come again. What is the question?
You want to repeat? You want me to repeat the question?
Yes.
Okay. Why bulbocavernosus is split into two parts in female and it is not split, it is as a whole muscle in male?
Because of the vaginal opening?
Because of
Yeah, because of the extra vagina. Yes. In male, they have only one passage. Through the one passage, they are going the same, doing the same function, urination and ejaculation. But we have a different opening because we have a uterus there, and uterus where the baby is going to, pregnancy is going to happen, and childbirth is going. We need a baby to come out in the world also. So sperm can go inside, child can come outside. We need an extra opening of this extra organ. That extra organ is not present in a male body. They don't have an extra, they don't need an extra opening. So from the same opening, they are serving the two functions, ejaculation, sexual, and the urination, both. So that's why this muscle is kind of looping around the base of the penis. So if this is the penis of a male and the muscle is, this is a bulbocavernosus. So this is the body, and on the downwards, the muscle will loop around. So what will it will do? It will hold this part, encircle, tight encircling. Okay. So now what is the function of this muscle, bulbocavernosus? Its function is that we all know that during this filling of the blood, during excitement phase, When erection is going to happen inside the penis, we need the flaccid penis is there, then erection is going on. Because of the erection, why erection is going on? Because more blood is going on towards the body and towards the penis. More the cavernosa, the anticavernosa, the channels, more blood supply is there towards that. So when rush of the blood is there, at that time, which muscle? Ischiocavernosus is going to put a lot of, the arteries are going on through this ischium, following this pathway. On these arteries, there is on the top, this is an artery and this is a ischiocavernosus. So now there will be compression from ischiocavernosus. So pumping action will be there over the arteries. So more blood will be going towards this sexual organs, even in female and in a male. We need erection. Okay, so erection will be there, and this pumping action, more blood should be there towards that organ, sexual organ. So now this is the action of the this ischiocavernosus. Now what the bulbocavernosus will do? Now after this penis is filled up with the blood and erection is there, now venous return should not happen, isn't it? If venous return will happen, erection will be not there, isn't it? So retrofall of the blood should not happen. So that's why what this muscle will do, it will create a tightness, automatically looping around, so like this. So it will close the venous return. So erection will be maintained and sustained. The more strong bulbocavernosus, more strong erection. More strong bulbocavernosus, more sustained erection. For 5 minutes, 10 minutes, 15 minutes, 20 minutes, if they are able to have this erection, it is because of the strong bulbocavernosus. So it means erectile dysfunction is one condition you might be aware about, ED. So in that case, if you create a strong strength into the pelvic floor muscle, so bulbocavernosus will be strong. So means erection will be sustained. So that's why pelvic floor has a very good result in treatment of the ED. Okay. So there are 4 muscles present into the superficial layer: STP, IC, BC, and the external anal sphincter. This is the external anal sphincter around the anal opening. This one is the organ, means anus, anal canal, and this is the external anal sphincters. Now, the ischiocavernosus muscle, IC muscle, this muscle, okay, is to provide extra rigidity of the erected penis by compressing the penile crus as a ring during the rigid phase of the erection, and helps maintain clitoral erection in female with the conjunction with the bulbospongiosus muscle. Both are working to sustain this erection. More blood supply we need, and more good erection we need. The bulbospongiosus muscle acts to expel remaining urine from the urethra after the bladder has completely, another function of the bulbocavernosus in the male is like once this urination is going on, okay, so once urination is going on, at the end, this muscle will create a strong compression, and because of this strong compression, the last amount of like for example, if this is the urethra of the male penis, and if the urination is going on, and this muscle is at the back, this is the bulbocavernosus. So now this is the way, this is the glans of the penis, this is the where the bulbocavernosus are present. So if the urination is going on, at the end of the urination, this muscle will create a strong compression. And because of this strong compression, the urine will not flow back, it will flow outwards. So extra, even the last drop of the urine, which is there inside this penis, will come outwards because of this extra compression. Okay, and if this muscle is weak, so you might have noticed the dribbling of urine is going on in male. So that means the muscle is not creating a strong compression. Muscles are weak. Okay, so this is the one part of urine flow test. We will go into the assessment. We will learn into the assessment. So this muscle, bulbospongiosus muscle, acts to expel remaining urine from the urethra after the bladder has completely emptied. In males, it also aids in the final stage of erection. Together with the ischiocavernosus muscle, it compresses the bulb of penis and the deep dorsal vein of penis and leads to the blockage of venous drainage from the penis. It acts as a pump that forcefully propels sperm out of the body from the prostatic urethra to the urethral uterus. Yes, very, very important. If the pelvic floor muscle is strong muscle, so means when the ejaculation, during ejaculation, very strong compression means more forceful ejaculation person will have. If more forceful ejaculation will happen, so means the sperm will go more toward, with the more force towards the uterus. If the ejaculatory force is not good, sperm will stay inside the vagina itself. So we need more forceful ejaculation force. So that is there because of the bulbocaval muscles. So means it is a muscle which is going to help in fertility again, isn't it? In a male. It acts as a pump that forcefully propels sperm out of the body from the prostatic urethra to the urethral uterus. This in female, it helps to empty the greater vestibular glands by constricting the vaginal orifice. So now very important again in female, as I told you that it is this bulbocavernosus muscle. This muscle is placed on the top of bulb of vestibule. Now, what is the bulb of vestibule? This is a bulb of vestibule. This is a bulb of vestibule in this image. If you remove this skin, labia minora and this labia majora over here. So beneath that, you will find this is a bulbocavernosus, and this beneath that you will find this one big gland which is present here. That gland is like a sponge, like sponge which contain the water, the liquid, so which can store the liquid. So that gland keeps secreting a lot of lubrication. So this whole gland is filled up with the fluid, and that gland has two openings. One opening is towards this urethra. So this is the urethra and this is a vagina opening. Okay, let me take a pen. This is the urethra. So this gland will give an opening around the urethra, both sides of the urethra. So assume the clock is very important whenever we are talking about the pelvic floor. So this is the pelvic clock. Many books it is written pelvic clock. So the same wall clock actually, assume there's a wall clock and on the clock, 12 o'clock position. Let me show you because you have to understand that. Yes, this clock, this is a clock, pelvic clock. So 12, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So clock concept is very, very important, and you have to assume the clock on the surface where you are. For example, I'm telling you about the urethra. So this is the urethra. Okay, so this is the urethra. So put this clock over the urethra. So what is there on the 12 o'clock position? So this is the 12 o'clock. This is a 6 o'clock around the urethra. This is 3 o'clock. This is again 9 o'clock. And this is around 4 o'clock, 5 o'clock, 6, 7, 8, 9, 10, 11, 12, 1, 2. Can you understand the small clock is there? Okay. Now assume the clock over the vagina. So this is the vagina. If I'll ask you what is present into the vaginal clock. So now assume a clock here. So 12 o'clock we have a urethra. 3 o'clock we have a bulbocavernosus. 6 o'clock we are having a perineal body. 9 o'clock again we have a bulbocavernosus. And this 3, 4, 5, 6, 7, 8, 9 up to 10. So from 2 to 10, the whole loop is made up by the bulbocavernosus muscle. So 2, 3, 4, 5, 6, 7, 8, 9, 10. Bulbocavernosus is present. And what is present at 11 o'clock? vestibular area. What is present at the 1 o'clock? Vestibular area. What is present at the 12 o'clock? Upper. There is a urethral opening. Okay, so this way we have to place the clock on. So this is the clock assessment. And if you put a clock over the anus, so this is the anal area. Okay, and in this anus, assume a clock 12, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So what is present at 6 o'clock? Perineal body.
Perineal body.
Yes. What is present at 12 o'clock? Coccyx. What is present at all these? External anal sphincter. Clear?
Yes.
Yeah. Okay. Now same clock, you can make it a big clock, pelvic clock. So this is the anal clock. This is a vaginal clock. This is a urethral clock. Now you can create a clock around the clitoris also, clitoral clock, very small clock. You can create a clock around vestibule, whole vestibule. So this was the whole vestibule. This is the whole vestibule. So vestibular clock is there. Okay. So now yeah, this one. So now this is around the vestibular clock is there. So in this vestibule, what is present at 12? Clitoris. What is present at 6? What is present at 6?
Perineal.
Yes. And what is present at 1, 2, 3, 4, 5? What is present here?
Bulbocavernous.
Bulbocavernous.
Yes. Yes. One side and other side. If you put this clock around the whole diamond, so this is the whole diamond. So what is present at 12? Pubic symphysis.
Pubic
6,
symphysis. Coccyx.
Coccygis.
3,
Ischial tuberosity.
Ischial tuberosity.
and 9 is tuberosity. Clear?
Yes.
Same way, this is the external and even inside also, internal also, I'll explain. So the concept of the clock is clear with all of you?
Yes.
Yes, ma'am.
Good. This is so in females, it helps to empty the greater vestibular gland. So now what I was telling you all were this one. So now in this clock of urethra, 4 o'clock and 6 o'clock, there are the openings of which is coming from this gland. So this gland is giving this opening. Can you see this light yellow color here? So we call this as a paraurethral glands or Skinny's gland. It is written here, paraurethral gland. So the position of the paraurethral gland is 4 o'clock on the left and 8 o'clock on the right. Clear? Clear, girls?
Yes, ma'am.
Same way, there's another opening, this is a vaginal opening, and we have a gland here around the vagina, 4 o'clock and 8 o'clock. This is a greater vestibular gland. So now, why we need these glands? What is the function of that?
It's for lubrication, ma'am, for
Yes.
release of their secretions in order to make sure there is less friction during penetration.
During penetration and even during that,
Even during.
opening and closing, even during urination also, isn't it? So whenever the urine is coming out, there's the expansion of the urethra. So this is the expansion means this expansion is going to put some pressure on the sides. And because of the pressure, the vestibule, bulb of vestibule will go under the pressure. And from that, there will be secretion of the fluid. The fluid will come here and it will provide a lubrication. So as many as time you are going for the urination, so this lubrication will keep providing moisture around the urethra. So female will not feel dry as well because this urine is acidic in nature and we don't need dryness over there. So this lubrication is supported by the paraurethral glands. So many times you are going for urination, glands will keep secreting and you will have a moisture around the area. Same way, during the penetration, or closing and opening around the vagina, if you are inserting the tampon, vaginal cup, so whenever there's an opening, so because of this opening, this structure will move outwards. When it will move outward, it will put pressure over the bulb of vestibule. Because of the pressure, the bulb will go under the compression. Because of compression, the lubrication will come out. And from this greater vestibular glands or the Bartholin gland, we can also take the other name of this is a Bartholin gland. So that is very, very important for this opening and closing action of these canals. Clear?
Yes, ma'am.
And during this, sometimes you might have heard a word squirting. What is squirting, girls? Anyone of you?
Sudden secretion and expulsion of fluid from the vaginal orifice
From
or
the
around
vagina.
orifice.
Yes,
Or
yes. So it means during the sexual intercourse, after orgasm, you might felt there's like, no, when you finish your sexual activity, you might found there's a lot of lubrication into that area. So that why this lubrication, this particular lubrication at that time is, we are calling it as a squirting. So what is this squirting actually is that when the penetration is going on inside the vagina, and from on the top of this female over here is a male. So the mons pubis of the male is putting pressure from the top, and from the bottom there's a penis which is putting pressure. So this bulb of the clitoris is going under the compression from both the sides, from the vagina and from the top. That compression and the maximum reflex, the pelvic floor, pelvic floor is going to create a sudden reflex just to complete this orgasm. So that reflex means sudden contraction of the pelvic floor will put a lot of compressive force over the bulb of vestibule. So the sponge will go under the compression. So if this is a sponge, and this is from the top, my male body is there, and from the bottom, this is the penis. So this sponge will go under the compression. Because of this compression, and this pelvic floor will also create a very strong reflex. Because of that, more compression, so means that sponge will be compressed. And because of the compression, more liquid will come out. So this is from the Bartholin glands. So this is what we are calling it as squirting. So whatever liquid was stored in the bulb of vestibule will come out because of the compression. Clear? This is the squirting. And because of this compression, the compression is not only falling over the bulb of vestibule, the compression is also falling over the urethra, because urethra is passing from the 12 o'clock position. So if this is my vagina, on the top, this is the urethra, isn't it? Outside, in the vestibular area, assume that this is a vestibular area. Okay, so what is top? On the top, clitoris, sorry, urethra,
Urethra.
vagina. So these are two openings into the vestibule. So now turn it that side. So can you see it is on the top, on 12 o'clock position. So vagina up, 12 o'clock, throughout, what is there? Urethra. So when there's a compression from the top, that compression will be over the urethra also. So whatever residual volume of urine is inside the urethra, that will also come out, isn't it? So that's why some females, they feel more kind of lubrication. So when the urine is also there. So it helps to empty the greater vestibular glands by constricting the vaginal orifice. Clear with this statement? And next is the anal sphincter muscle. This is the anal sphincter. External anal sphincter. So around the anus, there are two sphincter, internal and external. I'll explain you into the workshop. The part between this vaginal and the anal part is a perineal area or perineal body. Once you will remove everything from the top. So now in this picture, we have removed the bulbocavernosus, ischiocavernosus, and superficial transverse perineum. It is not there. So once you will remove it, So there will be another layer of the muscle which is coming all the way through the ischium. So this is the ischium. So all the way through this ischium, one muscle will keep coming towards the center. So this is a middle layer of the pelvic floor. And we called it as a deep perineal muscle, deep perineal muscle. Deep transverse perineal muscle is the name of this muscle. Okay. So one, it is deeper, it is not superficial, it is a deep, and the muscle of the perineum, around the perineum muscles are, and deeper. So deep, transversely placed throughout the length. Now ischium, so muscle is originating from here, 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 here. Look, muscle will keep originating like this. In origin, and insertion is where? Into the center. So now center, around the orifice. Insertion, insertion. Keep coming, insertion. Keep looping around. One side is coming, looping around the organs, urethra, coming, looping around the urethra. All the muscle fibers loop around the urethra, loop around the urethra. They will keep doing that throughout this length. So insertion is into the same muscle by creating a looping. So around the urethra, like this, is your insertion. Keep coming downward, keep coming downward. There will be vaginal opening. Okay, they will encircle the vaginal opening. Keep doing that. One side is doing this. It's a deep perineal, deep transverse perineal muscle. And we also call it as a compressor muscle because this muscle is compressing the canals. So when it is compressing the urethral canal, the name of this muscle is a compressor urethra. So deeper transverse perineal muscle is compressing the urethra. So name is a compressor urethra. And once it compresses the vagina, so name of that will be compressor vaginae. Okay. And some muscle fibers will go towards the perineal body. Look, this is the perineal body. They will go towards the perineal body. So this is a deep perineal muscle. So in the middle layer, as a whole, it is a one muscle, deep transverse throughout this towards the center, but the name can be more differential as per the area where the merging is. So merging is around the urethra, so compressor urethra. Merging is around the vagina, so compressor urethra. Merging is around this perineal body, so a deep transverse perineal. So these are the three muscles. As a whole, one muscle, but again, because we have to count that 17 muscle altogether. So this is again divided into three parts, depending upon which it is supplying. So now same way, let's talk about the right side muscle. So right side, okay, right side, 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 okay, okay, okay. Okay, looping around, looping around, looping around, keep going up, up, looping around, going up, looping around, going up, looping around, and then it will go looping around, it will go more up around the urethra, looping around. So this is a compressor urethra, 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 urethra. Now, as a physical therapist, try to understand one thing, that the compressive force will be high around which orifice? Urethra or vagina. If we have to create a more compressive force, the force will be around the urethra will be more, or around the vagina it will be more.
The urethra.
Urethra.
It has a smaller orifice.
Smaller orifice, even the distance is small. More force will be generated around the urethra, not around the around this vagina. It is more away. The force will, as a lever, try to understand. The force will be more high around the urethra. And compressor urethra is very, very important muscle to understand, and main muscle around the urethra. So when we are talking about the urine incontinence, so means the middle layer, the compressor urethra muscle is the major muscle of that which needs treatment. This you will be able to understand with this picture. I have taken this picture from one of very good book actually. Yeah, this is a picture. I'll share the PDF. I have a PDF of the book. Please remind me. So keep reading more. So in this picture, this is a bladder. Okay, so this is a whole bladder going up. sorry, excuse my drawing. It's just like this, bladders there. And this is a urethra. Can you see downwards? This is coming from here. It is coming here, urethra. When we're talking about the organ, so organ is made up with the smooth muscle. So bladder, the smooth muscle is detrusor muscle. Same way, this urethra is also made up with the smooth muscle, same muscle fibers, expansion of the smooth muscle. So it is also, urethra is also a smooth muscle. So now on this urethra, can you see this looping around? Is a compressor urethra. Okay. And some muscle fibers are coming from the vagina also. So even the more compression. And they will encircle throughout. This is a same muscle which is encircling the urethra. So now if you try to assume the length of the urethra, so how much was the length? The length was around, for example, 3.3 to 4 centimeter long. Okay, so this is a 3 to 4 centimeter long, all the way downwards. All the way downwards. Okay. So now from 20% up to here, 40%, 60%, 80%, which muscle is there? Compressor urethra. Yeah, middle muscle, middle layer. You cannot see the bulbocavernosus, superficial layer. You cannot see the levator ani also in this picture. So means 80% or more than 80 to 85% space looping around of the urethra is done by the compressor urethras. Clear with this, girls?
Yes, ma'am.
Some fibers of levator ani will be also there where the organ will lie down. Okay, so that will be supportive muscle fibers. Pubourethralis, the name of that is a deeper muscle. I'll explain you in the deeper layer. So that is a different. So only 10%, 10 to 15%, hardly, of the levator ani, deeper layer. And the external only 5% muscle fiber action will be there from the bulbocavernosus. Only 5%, not even that. Okay, so means very less support from the levator ani, and even whatever levator ani is there, it is a supportive to the organ. But the sphincteric action is done by the compressor urethra. So means external urethral sphincter, when we're talking about, there are two sphincters, external anal sphincter and the external urethral sphincters. So when we're talking about urethral sphincter around the urethra, that is made by the middle layer and this muscle. Clear?
Yes.
So means next time when the patient is there for urine incontinence, so will you train the levator ani on bulbocavernosus, or your aim should be training the middle layer? So
The
now
middle
how,
layer.
middle layer. So how to train the middle layer? You cannot palpate the middle layer. You cannot assess the middle layer. So how to do it? By, that's why, this transvaginal stimulators, EMS, is very important. To we will keep giving this whole pelvic floor strength by digital, exercises and everything. But the stimulators, IFT is there. So place IFT outside. So that will have a deeper effect. Even from this, there's an orifice, that's a vaginal orifice, which is present here. So this is a vaginal orifice on this side.
I have a question.
Yes, please ask.
Is individual muscle strengthening possible
No,
in any case?
no, not possible. Not possible here. We can divide into two parts, anorectal and this ugenital. So you can focus on to more onto the, one part, but the action will be from the posterior side also. Okay.
Okay.
60% will be on that particular where you are focusing, and 40 will onto the other parts. So more can be there, but not without the whole muscle is going to work as a pelvic floor.
Okay, so here in general, we'll need to train all the muscles to target compressor urethra particularly.
Yeah, we have to, and more focus will be onto the center of this transvaginal. So insert your finger inside, ask the patient to create a compressive force. hold this, hold your finger. So that kind of endurance training is important. And
Alright.
stimulating the pelvic floor, creating that magnetic field and the stimulations of this whole muscles. So this is the, like for example, this is the vagina. So in this vagina, it's the transvaginal electrodes, which you can, I'll explain you that also in rehab protocol. So that will automatically create an action of the muscle. And from outside, there's an IFT you can apply.
Okay, ma'am.
So this is a deeper muscle, a middle muscle. And now after that, there's a deeper layer. So now always the muscles are in a fashion like superficial layer, the skin, the fat, then superficial layer, then fascia, then middle layer, then fascia, then the deeper layer, and then fascia. This is a kind of, fascias are very small, thin covering. So same way, let's go to the deeper layer. When we're talking about the deeper layer, so try to see it from the superior view. So this is the superior view of this muscle. We call this muscle as a levator ani muscle also, coccygeal muscle or levator ani muscle. All these other names can also be like endopelvic fascia or what else? Bowl-shaped muscle, hammock-shaped muscle. So this levator ani is providing that shape. That's why we are calling it as a hammock bowl shape. So now this is the individual layer of the muscle, individual muscle. Look, as a whole deeper layer. So can you see from this to the outer walls are not there, pelvic walls are not there. So this is it's like a bowl shape, as a hammock from front to back, as a hammock shape, or as a trampoline, it is going to work also. So now the levator ani or the deeper layer is the most important muscle of the pelvic floor. Why? Because it is as a whole muscle from front to back, side to side. So this in this picture, from front, side, and back. Look, this muscle is going. So this is a levator ani muscle or deeper muscle. All these muscles. Okay, and there are two accessory muscles are also present here. This one is the piriformis, which is a supportive muscle, supportive wall, and this is a obturator internus muscle. This is an internal obturator internus. This is the obturator internus, sorry. And from this, so these are two supportive muscles, accessory muscles, not a pelvic floor, but supportive muscle. But otherwise, all this is a deeper layer. And on this layer, if this muscle is strong, the organs will place, they will be supported well. The levator ani is the most important muscle of the pelvic floor, which gives bowl, hammock-like shape to the pelvic floor, on which pelvic organ rest. So its main function is to provide support to the pelvic organs. The muscle has the highest resting tone in our body. It has a 70% of type 1 slow twitch muscle fibers. Slow twitch are responsible for what? Endurance and stability. So 70% type 1 slow twitch muscle fibers to maintain muscle tone for long period to sustain contractions and provide postural stability. So this is a muscle of support and the stability, because it is covering everything. So stability from one side to other side, east to cross to other side, pubic symphysis to coccyx. So stability, muscle of stability. And this muscle has a 30% type 2 fast twitch muscle fibers to increase muscle tone quickly for sudden increased abdominal pressure during sneezing, coughing. So whenever we are lifting something, there is a sudden sneezing, coughing. So this muscle has a fast twitch action. So closing, sudden closing and trampoline kind of effect will be provided by the muscle, by this fast twitch muscle fibers. Reflex contractions of both type of muscle fibers are important for pelvic organ support and keeping urinary fecal incontinence and onset of sudden activities. So try to understand this line, that this 70%, 30%, now 70% means slow twitch. So means they are maintaining the muscle tone. So when we need to maintain the muscle tone, I need tone, okay, I'm sleeping, okay, during sleep, during the night, the tone should be strong, isn't it? If the tone is strong, the leakage will not happen. If the tone is not strong, the muscle, slow twitch muscle activity is not strong, or pelvic floor is not good pelvic floor. So the patient will have nocturnal enuresis, voiding, bedwetting at the night. So all the patients who are having bedwetting at the night, so it means this slow twitch muscle action is not there. So tone or endurance it should maintain is disturbed somewhere. So in that case, our mind should think, oh, there's a weakness in the pelvic floor. So we will do transvaginal, all this, rehab in that case. Because we have to acquire the levator ani strength. That levator ani is responsible for the maintaining the tone even whenever I need, even during the sleep. I'm going for sleep for 8 hours, 10 hours, kind of continuous sleep. That should not disturb. So that tone will be provided by the slow twitch muscle fibers of levator ani. So this is one action. And the second is, I'm a female and I don't know when I'm going to have sneeze or sudden cough, isn't it? If sudden sneeze is going to happen, so at that time, what is going on into the sneezing? Intra-abdominal pressure will increase. So that will fall over the pelvic floor. And at that time, whenever intra-abdominal pressure is increasing, the pelvic floor should suddenly come as a trampoline and try to place a counter pressure. Okay, that is happening because of the sudden activity, fast twitch muscle fiber action. So 30% muscle fibers, so suddenly they will close the orifice. So this is a urethra. They will close the urethra and come upward, inward. So this is the pelvic floor. This will happen when there is the intra-abdominal pressure increase. So during exercise, lifting, jumping, skipping, okay, running. So at that time, there will be trampoline effect of pelvic floor. So that is provided by levator ani. So this around the sphincters into the center, sudden compression and upward lift, inward lift. So sometimes sudden activity. I need sudden action. Okay, so that is done by the levator ani. So the patient stress incontinence because of the stress. I was jumping and there was a leakage. So means this levator ani is affected in that case. Note the compressive urethra, levator ani. Okay, understood this? Sheetal has pelvic model. If you want to use it now, if it will make it more easier for you. Don't worry, Shraddha, I'll explain you into workshops. So Sheetal, do I have to bring my model or you will bring?
Ma'am, I have it. I'll
Okay.
just show you the what I have. You continue, I'll just get it. So
All
you
right.
continue, ma'am, I'll just get it.
All right. So this is 70% type 1 slow twitch muscle fiber to maintain muscle tone for long period to sustain contraction and provide postural stability. And 30% type 2 fast twitch muscle fibers to increase muscle tone quickly for sudden increased abdominal pressure during sneezing and coughing. Reflex contraction of both type of muscle fibers are important for pelvic organ support and keeping the continence during the onset sudden activities. And now this pelvic floor, when we're talking about, is again divided into 3 parts. One is the pube, as per from where the muscle fibers are originating and where they are inserting. So now the first is some muscle fibers are originating from the pubic bone over here. Okay, so this is one side and this is the other side. This is the muscle fibers. So they will originate from here and they will insert into coccygeal tailbone like this. So they will from front to back, front to back, all this central, more medial layer is the from pubis to the coccyx, pubo-coccygeal muscle fibers, more medial towards this orifice, towards the center, pubo-coccygeal muscle fibers. Next is some muscle fibers are going to originate from the ilium. Okay, so ilium is this part, but not directly from the ilium, but it is from the fascia of, this is the obturator internus muscle, and this is the fascia of obturator internus muscle. So the muscle fibers are originating from the fascia of obturator internus muscle, this one. And the merging will be into the coccyx, like this. So from lateral to the posterior. So it was anterior to posterior and they are lateral to posterior. Okay, so this is this one, this green color, iliococcygeus, all the way down posterior side. So this is a fibers, iliococcygeus fibers. And the third one is we are having this ischial spine. If you will see from the superior view, this is ischial spine. So from this ischial spine, some muscle fibers will originate and the insertion will be into the coccyx again. Okay, so this is a posterior layer, posterior part. So this was the anterior to posterior, this is the lateral to posterior, and this is the superior to posterior, like this. Sorry, inferior to posterior, like this. So this is the coccygeus muscle fibers. So again, levator ani is divided into three parts: pubococcygeus, iliococcygeus, and coccygeus. Clear, girls? So shall we resume our session here, and other things we will do on the workshop. I hope today you got some understanding about pelvic floor. There are many piriformis, obturator internus, accessory muscles, and there's a subdivisions of this muscle, pubococcygeal. All this we are going to understand in workshop. I want you to just click up one screenshot from this. Just take a screenshot, please, and please read it. It is very important. Whenever you have time. Yeah, this slide. You should be understanding what is all these conditions. Chronic pelvic pain, interstitial cystitis, chronic pelvic pain, vulvodynia, cyclitis vulvitis, aesthetic vulvodynia, bulbar vestibulitis, endometriosis, constipation, pudendal pelvic dysnergia. This slide also, pelvic puborectalis syndrome, coccygynia, vaginismus dyspareunia. Please read this. These are the conditions, the pathologies, the problems, and how it is affecting the pelvic floor or how the pelvic floor is affecting them. We are going to discuss into the pelvic floor. It will save our time and it will give us more clarity.
Ma'am, could you kindly share the previous slide again?
Yes, please.
Yes.
Done?
Yes.
Okay. So, hi Sheetal, can you show me the model? She's there.
Yes. And this is what I have.
From the down, yeah, inferior side. Yes. Okay. It will work. Okay, so I will not bring mine. So otherwise I have to carry 2 kg of weight. All right. Thank you, Sheetal. I will not bring mine. Okay. So please bring that. And if you have an empty pelvis without the muscles, any one of you have, please bring that also. Good. And dilators and any other tools you are having? Any other tools anyone is having? I'll bring, don't worry. Okay. I need a button electrodes. If anyone is having button electrodes, small. Okay. Or a simple electrodes, I will explain. No problem. Okay. So I hope that today you got some understanding, and that was it will save us some time, but still some girls were not here. I have to give you recap, but I will keep sharing you every day one thing which will give you more clarity about the conditions, and even there are some videos about pelvic floor. I'll keep sharing that also. Okay. So don't miss anything, any videos, and go through it. Take a 10 15 minutes of time.
Ma'am, please
Yes,
share the
ma'am.
PDF of the book which you mentioned earlier.
Yeah. Sure. That is
Thank you so much, ma'am.
all right, everyone. I hope today was a fruitful session, and see you on Saturday, Sunday. Excited to meet you. Nice faces.
Yes.
Yeah.
Thank you, ma'am.
Thank you, ma'am.
Okay, dear. Bye-bye.
Bye.
Thank you, ma'am. Thank you.
Bye, Dr. Shraddha.
Bye, ma'am.
So I'm ending the session.
Yes.